webinar. So welcome to the WASH Nutrition and Early Childhood Development, New Evidence in ECD and Findings from the Field. This webinar is co-hosted by the USAID WASH and Nutrition Community of Practice, as well as the WASH Plus project. We have two panelists today who will each speak for approximately 15 minutes, and then after that we'll open up to questions. Our first speaker is Jenny Orgle, who is a program director for the Nutrition at the Center program at CARE USA, and she leads a team of technical advisors based in the U.S. who work closely with each of the 4 countries where the Nutrition at the Center program is implemented, and she ensures the effectiveness of each of the program components. And after Jenny, Maureen Black will speak with us, and she is a professor in the Department of Pediatrics at the University of Maryland School of Medicine, and she's chief of their Division of Growth and Nutrition. And now I will turn the webinar over to Helen Petach, who is the Biomedical Senior Advisor and AAAS Fellow working with the Environmental Health Team at USAID's Bureau for Global Health. And she'll share some background information and context for the webinar. Helen?
Welcome everyone, and thank you very much for joining us today. I just wanted to give you a little bit of context for the webinar. We have been hosting over the past year a community of practice called the Nexus of WASH Nutrition and Food Security. And our goal is to really understand the evidence base and good programming practices for programs that would integrate, say, WASH and nutrition and address WASH nutrition and food security needs. If you're interested in this community of practice, I welcome you to join. It's an open community. Dan Campbell, whose contact information is on this slide, has been handling the organization of keeping people informed about what's happening on the community of practice and also collecting information to store there. So we try to encourage a discussion, we host webinars, we try to include articles and evidence-based studies and so on, really to build our understanding of this field. So we do welcome you all to enjoy or to join if you're interested. I just wanted to let you know that both the USAID Water and Development Strategy that was launched almost a year ago and the USAID Multi-Sectoral Nutrition Strategy that was just launched last month in May are both very committed to this mission. So the water strategy emphasizes links among WASH, nutrition, and food security. The multi-sectoral nutrition strategy is committed to making nutrition initiatives more effective by integrating key hygiene actions as essential components in all of its nutrition programs. So those hygiene actions include WASH interventions such as safe drinking water, hand washing with soap, and so on. So please join us in the future as well. We try to host webinars on a quarterly basis, and we welcome your participation. I'd like to turn it over now to Jennifer Orgle. I think we'll be very interested in what she has to tell us. Thank you.
Thank you, and good morning, everybody. In my presentation today, I will give a brief background to the Nutrition at the Center program, present some studies on EE, that is environmental enteropathy, and why we think addressing this is critical to reducing stunting, and finally talk a bit about our baby wash study with Cornell. Next. The Nutrition at the Center program is a 5-year privately funded integrated program which works across social behavior change, health, WASH, and food security sectors to improve nutritional status of women between the ages of 15 and 49 and children under 2. Next. Central to the program is its learning agenda, which will further define the impact of integrated programming and assess the impact of environmental enteropathy on the growth of children to identify feasible and acceptable solutions for communities. Next. Based on a number of studies, key causes of stunting have been categorized into 4. We all know that malnourished mothers generally give birth to babies that are smaller and shorter than normal. And according to a study by Ray Material, 20% of stunting can be attributed to intrauterine factors, and about 30% of it is attributed to poor feeding behaviors. 5 studies in the Gambia put diarrhea as 10% cause of stunting, and studies indicate that between the ages of 6 and 18 months, children in developing countries have around 9 episodes of diarrhea a year, and literature suggests that children grow at catch-up rates between these episodes and therefore recover the deficits due to anemia. And so, but however, studies undertaken from the Gambia and other places. In the Gambia, the study was conducted on 400 children and showed that all young children were affected by environmental enteropathy and have attributed 40 to 60% of this as the cause of stunting. Next. The condition is described as a subclinical condition which causes the flattening of villi in the gut, reducing its surface area and resulting in decreased nutrient absorption and infiltration of microbes. EE is caused by chronic exposure of children to bacterial pathogens in their environment from human and animal feces. Next. In children with EE, when the surface through which nutrients must be absorbed gets thickened, as we see here, there is increased permeability to large molecules and cells. And so there is a leakage into the blood which causes chronic immune activation. And this means that nutrients which were meant to ensure growth are then diverted to fight infection. Next. Next, please. Observational studies in a number of countries have shown that crawling and toddling babies, through their natural exploratory behaviors, ingest substantial quantities of soil that is contaminated with human and animal feces. Data from a Zimbabwe study estimates that E. coli intake from injection of chicken feces is 4,000 times greater than either from untreated drinking water or soil. A study in Malawi of a population of 418 rural children between the ages of 2 and 5 also found that although children had good access to wash facilities, including good sources of water and used pit latrines, and also had relatively good food security and dietary diversity, which even included animal protein, 87% of these children still showed evidence of the presence of E when they were tested in the labs. It was found that 51% of the households from which these children came from had animals sleeping in the house at night. Next. This slide just shows other observations which exposes children to feces in Zimbabwe and Peru. Next. This slide also just shows the amount of daily intake of E. coli of a child from their environment in the Zimbabwean observation that I just referred to. Next. So all this evidence indicates that traditional wash interventions such as providing latrines or hand washing do not effectively address bacterial exposure of infants from soil. There's a paradigm shift from the thinking that ensuring clean water and hygiene to prevent diarrhea would completely prevent stunting in children to the current knowledge that new approaches are needed to protect developing children from the constant and cumulative risk of human and animal fecal contamination. In terms of child mortality, diarrhea remains a main cause, but in terms of nutritional status, EE puts children more at risk. I want to say here that a recent pooled analysis of 9 studies concluded that diarrhea is a minority contributor of growth faltering, and EE in children so far is chronic. Next. The hypothesis suggests that EE is a major cause of postnatal stunting, anemia, and immune incompetence, but can be reduced by reducing exposure of infants and young children to feces through a combination of wash interventions and changing household management of animals and children's play spaces. While animals pose a significant threat to the health of young children wild animals pose a significant threat to the health of young children. In multiple ways, they are also critical to the resilience of poor people, especially women who depend on free-range chickens for income and nutrition. Livestock contributes to livelihoods for about 3/4 of the extreme poor. And so for this program, maintaining the benefits that small livestock provide while protecting children's growth and development is critical to achieving the program's objectives. Next. This slide just shows the different routes through which pathogens are passed to children. And on the right side, we see where we have the protective play space. So it just shows how the protective play space can serve as a barrier in the transfer of pathogens to the children. Next. Despite current knowledge, there are still gaps. This slide shows a number of questions we in this program would like to answer. So far, the first 3 questions which I have I have emboldened are the 3 questions that the Nutrition at the Center program will answer. These are how we identify and implement socially acceptable interventions which reduce child exposures to human and animal feces, how we effectively promote interventions which will contribute to the changes in the management of animals without undermining the benefits that small livestock provide to households, and how we influence changes in where children play and eat. For the last 2 questions, we hope to raise additional funding or work with others to address them. Next, please. What are we doing at the Nutrition at the Center? How are we addressing EE? CARE, in partnership with Cornell University, is carrying out a baby wash study which will engage 6 communities in Zambia to ensure that smallholder farming families in rural communities globally will reap the benefits that small animals provide and simultaneously provide their young children with safe environments. Why do we refer to this as a baby wash? Baby wash because most of our interventions usually focus on caregiver behaviors. That's hand washing before food and among others. This study focuses not only on the behavior of the family but also on the behavior of children, where the children play and what they put in their mouth. This slide shows the vision of the intervention, the study, and then the objectives. For time, I'm not going to read through it, but we will have it there. Next. The research priorities include developing and testing protective play spaces to protect developing children from contaminated soil and animal feces, create sufficient awareness among communities about EE so that initiatives can actually originate from them, or they would play lead roles in designing and identifying solutions to the problem. Identifying and testing feasible strategies to change animal and child care behaviors, and addressing sanitation and hygiene behaviors to reduce child exposure in high-risk areas. The illustration on the right shows an example of child play space with a fence around the child to prevent the animals from wandering in where the child is playing and the child from wandering into where the animals are likely to be. Next. The study will combine community-based participatory approaches and facilitate dialogues in 6 villages in Zambia by engaging 60 to 90 households or families with free-range small animals and children between the ages of 6 and 24 months. Due to the sensitivity of this study, which calls on families to change behaviors with regards to what many of them see as a family wealth. I mean, example, we are asking and encouraging families to keep out animals from sleeping in the house, which they see as leaving out the family's wealth, which exposes it to theft and loss. Because of this sensitivity, it is important that families are engaged in the search for solutions that are feasible, affordable, and effective. Communities will be engaged in a number of ways, including extensive education, as indicated here, sensitization of entire communities, and training of some community members to actually participate in observations and in the study itself. Next. There will be 2 groups in the study. I mean, out of the 6 communities, in one group will have 3 communities which will have commercial play spaces introduced to them, and the other group will just be supported to propose and test interventions. There will also be they'll go through 2 trials. In the first trial, selected households will test different interventions for a month and assess the effectiveness and acceptability of these solutions. The most effective interventions or solutions will be rolled out in the second trial to all households for 3 months, and the second assessment will be done. Next. Challenges. Challenges include limitations of data and knowledge. EE is a relatively new, and there is little data on it. I mean, so far, not much has been done on EE compared to preventing the work that has been done around diarrhea, for instance. For now, we have solutions to managing human feces, but not for animal feces. There is therefore the need for additional research to inform more effective programming. There are the challenges associated with testing EE in the field. Laboratory testing usually requires feeding children with non-absorptive sugar and testing their urine, which can be quite difficult if you are in the field in Africa or Asia. Animal feces are ubiquitous. Household livestock is found almost everywhere around the house, and it is difficult to restrain animals, for reasons such as you need to vaccinate penned animals, and the thinking that free-range animals are more valuable or nutritious. If restricting animals is difficult, does the answer lie in restricting the movement of children? Families may also not be accepting to the idea of restricting their children. And then, one other challenge, last but not the least, is the effectiveness of the proposed play spaces. Will chickens fly into these play spaces? Or what? We need to, there are so many questions that we need to ask and answer there. Next. Finally, We are not saying that we have all the answers or we have the perfect solution. We need to continue to work with the development community, communities of practice, and peer organizations to answer some of the questions that need to be answered and collect more data, find out, learn more about this area to be able to more effectively address environmental enteropathy. Thank you.
Maureen,
Welcome,
go ahead.
and thank you very much. My name is Maureen Black. And we're going to be discussing new evidence linking nutrition and early child development. Next. The objectives are to discuss integrated interventions, that's integrating, for example, nutrition and early child development, looking at the long-term effects of several recent studies on early child development, looking at recent trials where nutrition and child development have been integrated, and reviewing some future research recommendations. Next. We've learned that there are over 219 million children in low and middle income countries who do not reach their developmental potential. As you can see, these are primarily in Africa, especially sub-Saharan Africa and South Asia. Next. So the background is that we know that in terms of sustainable development, we need healthy and productive citizens. We also know that the building blocks of health and well-being begin prenatally during the first 1,000 days through early nutrition and through nurturance with families and protection from illness. But development continues through childhood and adolescence. It doesn't end at the first 1,000 days. We also know that when we think about child development that it's a very dynamic process. There are time-sensitive genetic and environmental interactions, and in line with those, there are also threats and interventions, and they vary both by the dose and by the duration. So we'll talk about how some of those relate to early child development. Next. This is a conceptual framework that is often used in looking at child development, and it emphasizes that development is influenced by both psychosocial factors as well as biological factors. It also emphasizes that there are multiple components to early development. So here we've represented sensory motor, socio-emotional, and cognitive language. And then as children grow, these influence their school performance, economic performance, and ultimately the next generation. Next. Then a recent publication of the Annals of the New York Academy of Sciences, Kay Dewey and I edited 20 papers that focus on integrated interventions. That's integrating nutrition and child development. These papers are all available through open access on the Wiley website or on the New York Academy of Sciences website. Almost each paper is written by someone with expertise in nutrition along with someone with expertise in child development. So they really illustrate how one would integrate programs. Next. An example of an integrated program might be a home visiting program that includes both nutrition and early child development. So for example, in terms of nutrition, there may be a focus on breastfeeding and complementary feeding. But along with that, there's not only what is fed, but how it is fed. And that is often looked upon as responsive feeding. Well, responsive feeding is really a derivative of the relations between the parent and child and lends itself very easily to including responsive play and a learning curriculum. So in this way, you can incorporate both nutrition and early child development into a home visiting curriculum. Next. This slide portrays early brain development and emphasizes the critical component of timing. I've drawn a box around the first 1,000 days, and you will see it begins at conception and then ends at age 2 years. Well, during that time, there's a tremendous amount of brain development that is occurring. Myelination starts prior to birth, and you can see in that first 1,000 days the visual and auditory cortex come online, as well as receptive language and speech production. So those are very sensitive periods that it's absolutely essential for children to have not only adequate nutrition, but adequate environmental stimulation to promote this early development. Development certainly continues, and you can see synaptogenesis and pruning extending up to early adulthood. But the bulk of what's happening is happening very early in life. Those are the building blocks. Next. When we look at integrated interventions, there are some advantages and there are also disadvantages to consider. So the advantages are that children who are at nutritional risk and at risk for child development are often in the same geographic location, and it's the same time. We see that health and nutrition are often the only sectors that are reaching young children, so it makes sense to work together. And that children with poor health and nutrition are the same children who are at risk for poor development. It's often lower cost to have integrated interventions than standalone interventions. But there are considerations, and that potentially could be disadvantages. And that is the first one listed is that the health and nutrition sector focuses primarily within the first 12 months with less contact beyond that. And you could see from development that one needs contact beyond 12 months as well. Overstretching the services of community health workers is an enormous concern, and having them have messages both related to nutrition and development really requires some innovative programming so that we don't overload the worker or overload the mother. As we can see, the nutrition focus early in life is, but the child development extends through childhood. And of course, there's the issue of sector collaboration. These issues are covered very well in the annals of the New York Academy of Sciences that I mentioned. There's evidence related to integrated interventions. This is emerging evidence as we're having more trials come online. And what we see is that most of the evidence is from the home visiting trials, as the example that I gave you. The benefits appear to improve with a longer duration of intervention. But there's really been limited evidence from programs at scale, and that's what we need. And the looking at how we can scale up programs that include both health or nutrition messages as well as early child development messages. Next. So what are some of the evidence gaps? Well, integrated programs at scale are a gap, as well as long-term follow-ups. I'll show you 2 follow-ups today, but we certainly need more long-term follow-ups. All of these programs have to attend to the issues of quality. So it's not just a program, but how are they implemented and what's the attention to quality. There's been attention to the preschoolers, those are the 3- and 6-year-olds, but we also need attention to infancy. You could see during the first 1,000 days, we need attention to the quality and to the sustainability of programs very early on. Identifying the essential program components which will help us move to scale, and really looking at strategies that have effects both on children's early growth as well as their development. Next. There are 2 longitudinal programs that I thought you should be aware of. These were programs that were published this year in Science, which is really a top-tier journal, and we'll discuss both of them quickly. Next. I think we skipped a slide. Oh, thank you. This is the what's called the Abecedarian Project, which was conducted in North Carolina among low-income African-American children. It was begun 35 years ago. The intervention was that children received a preschool that included an all-day preschool, healthy nutrition, and access to health care for the first 5 years of life, and then they were followed up through age 35. So the outcomes are that those who received the preschool intervention were 4 times more likely to finish college. And what the most recent Science paper shows is that they had a lower risk for cardiovascular and metabolic diseases, particularly the males. So these are the biomarkers, including systolic blood pressure, metabolic syndrome, vitamin D deficiency, obesity, and hypertension. So this early intervention had payoff over 30 years later on very, very hard objective outcomes, which are health risks. Next. This illustrates that the changes in BMI began during the preschool years, under age 5. And so what you can see is that those who were in the preschool were more likely to maintain a healthy weight, whereas those in the control group did not. So it illustrates that interventions very early have a payoff in adulthood. Next. The other longitudinal project is a follow-up of the Jamaica trial. This also was a randomized trial. This one included weekly home visits for 2 years by community health workers among stunted children recruited at age 9 to 24 months. They also received some nutrition, but there were not long-term effects of only receiving the nutrition. The follow-up at age 20 had to do with wages, and you could see that those who received the intervention very early in life had increased wages by 25%, such that their wages then were equal to the non-stunted controls. So these are 2 pieces of evidence that illustrate the timing very early in life has payoff in adulthood. Next. There are 2 other trials that I wanted to share with you quickly. These are integrated trials conducted in low and middle income countries. So the first one is the Pakistan Early Development Study that is published just recently. I believe it's out this week in The Lancet, done by Aisha Yousafzai. And they incorporated both nutrition and responsive stimulation that was done during the first 2 years of life by lady health workers in Pakistan. So if you look at the responsive stimulation component of the intervention, then they had beneficial effects at age 24 months on the children's cognitive, language, and motor scores. If you look at the nutrition component of the intervention, which was micronutrients, you see an effect on linear growth, small but significant, beneficial effect on language scores, but not a change on hemoglobin. There was not synergy between the nutrition and responsive stimulation. In other words, they both had an effect, but there was not synergy between the 2. It's a very exciting study, and I would encourage you to take a look at the recent Lancet for more details on it. Next. Another study that was done in Bangladesh looked at the differential effects of stimulation based on children's nutrition status. So they looked at children who had iron deficiency anemia and those who did not. And these are children in that 6 to 24 month age range, again in the first 1,000 days. and they found there were stronger benefits for the children without iron deficiency anemia when they looked at the children's development as an outcome. The children with iron deficient anemia were treated with iron, and their iron status improved, but their development lagged somewhat. So it illustrates that the dose and duration of iron deficiency matters, and the timing of the intervention may actually have been too late. So if we're trying to promote early development in our children, we need to attend to both the nutrition and the early stimulation, and to do it at a time that's as early as we can do before negative events have occurred. Next. So if we look at the evolution of micronutrients in cognition, what the observational studies have shown us is that single micronutrient deficiencies are associated with negative indicators of children's development. So iron deficiency is associated with fatigue and wariness and low mood and poor development, and zinc is associated with poor growth and low activity and motor. But the prevention trials have had some inconsistent findings. Many of the trials are somewhat hard to compare because they vary in terms of timing and dose and duration. But what's happened is we've turned to multiple micronutrients because children who experience one deficiency are often experiencing another deficiency. Next. So the multiple micronutrients, as we said, the deficiencies often occur in combination along with poverty and are associated with a poor quality diet and limited access to diverse nutrient-rich foods. So we're evaluating the impact of improving one micronutrient in the context of multiple deficiencies. So we have to attend to the competition or interaction among micronutrients and also the timing of when to intervene. So what we see coming online now is the integration with early childhood interventions so that there are multiple micronutrients along with the early childhood interventions. Next. So this is where the field is at this point, and you'll see the emergence of more trials. We're doing one in India called Grow Smart that we're in the process of writing up. But where the field has moved is to really look at the timing and the interplay among environmental variables. So that is both the nutrition and the early child development. So we need to look carefully then at the dose and duration, both of the threats and of the intervention, and to conduct what are rigorous multi-level trials that evaluate the effect of the nutrients, the effect of the early childhood interventions, and the synergy between these two. The capacity building among sectors and among workers is certainly something that we need to attend to as we look toward what we learn and toward scaling. There are also the economic and health indicators. As you've seen, those are the things that made their way into the science publication. So we need a focus on the first 1,000 days with longitudinal extensions. Next. And I thank you very much.
So perhaps at this point we could take some of the questions out of the question box and pose them back to our speakers and learn a little bit more about these topics. I'd like to start with some of the questions that are already in the question boxes, and while we're answering these, please don't hesitate to add your own. So the first of these questions is, what are the most common effective indicators that are currently used in the field of WASH to show impact of integrated programming of WASH nutrition and food security? And maybe, Jenny, we could start with you and you could speak a little bit about indicators, and then perhaps we could switch over and get input from Maureen. So I'll turn it over to you, Jenny.
Can you repeat this, please?
Yes, I can certainly repeat the question. So the question is, what are the most common effective indicators to show impact of integrated programming in WASH, nutrition, and food security. So it's really focused on learning more about indicators.
The key indicator is reduction in stunting. One of the key indicators would be reduction in stunting, and another indicator would be equitable access to quality food for children and in the target group. I would also say that.
Maureen, do you have? Oh no.
Hello. I would also say, just a moment. I would also say that another key indicator for can you hear me? There's noise in my background. Hello?
Jenny, we're hearing you very clearly.
Hello? Yeah. A service is the service provision, the quality of services of frontline workers who provide, who ensure the provision of the integrated services to communities. That would their knowledge and the quality of services that are provided is another key indicator. Thank you.
Mm-hmm. Yes, I could add a few comments regarding the effective indicators of WASH and food security. If we think of the child level, as Jenny mentioned, certainly that the child's growth and indication that one could look at rates of stunting, which is a bit of a late indicator. A little earlier would be measures of morbidity that the child may be experiencing from an environment that is not as hygienic as one would like. There are also indicators of inflammation if you are doing this requires a blood draw, but to look at the C-reactive protein, to look at indicators of inflammation that are there that may interfere with their absorption of micronutrients, but an earlier one would be, their morbidity, their diarrhea or respiratory infection. From a family level, there are indicators, again, as Jenny mentioned, in terms of thinking about food security, their access to healthy foods or to the kinds of foods that young children need, which are energy-dense and micronutrient-rich foods that one could look at by asking families or by surveying the foods and the portions and the frequency that they're providing those foods to children. I mean, we also look at, this moves into the question, had both WASH and food security. When we look at food security, I think that we would want to look at not only the foods that are offered, the frequency that the foods are offered, but to some extent, and this is where the child development comes in, is as how they're offered and how families facilitate the child eating the food. So facilitating that would mean, are the child's hands washed before they have the food so that you don't have risk of contamination either from the child or the family, and do they promote the child self-feeding as they get into the age of complementary feeding?
Excellent. Thank you for those inputs. I think the next two questions really target Jenny's presentation, and they are both about environmental enteropathy. So Jenny, the first question is, do we have some knowledge why environmental enteropathy has been associated with stunting but not wasting? And then secondly, in the study in the Gambia, what were the ages of the children who were studied?
Okay. There is a lot more data around the contribution of environmental enteropathy to stunting than to wasting. I mean, definitely because environmental enteropathy is chronic, and unlike diarrhea, it's not something that manifests itself immediately, and it tends to be a longer term, and so contributor, and so it remains in the child for a longer period. And there isn't very much data, I mean, to help me to explain, but I think that is one of the reasons. And in the Gambia, the children studied were between the ages of 2 and 5. Does that answer the question? Yeah.
Those are great input. Yes, that's really good. Another question came in. So the comment is, it's great to see the support for operational or implementation research on integrated programs. So thank you for that. It is clear that for child health and development, we need nutrition, ECD, and WASH. And without one, children do not reach their full potential. The question is, do you foresee an implementation study on integrating all 3 of these interventions?
You know, I would love to see an implementation study on integrating them. And, you know, I think that they work very well in terms of integrating them. The little example that I just gave of integrating nutrition and the WASH by ensuring that children wash their hands, putting that into a nutrition, and the child development piece of incorporating responsive feeding into it is a small example of how you could do it. What the challenge is to those who are developing the intervention is to really make them integrated, as opposed to now we'll have the nutrition messages, now we'll have the intervention, now we'll have the WASH intervention, and now we'll have the child development intervention. That has the potential of being overwhelming. So if we are prepared to really come up with integrated interventions so it appears seamless, I think it's the highest likelihood of success. And I would certainly encourage both investigators and donors to move toward an implementation of integrated interventions.
Thank you. I want to move on to a comment from Maureen Mucha. She's contributing, I believe, to our discussion of indicators and includes many WASH indicators in her discussion. Percentage of households with access to an improved water source, percentage of households with access to sanitation, number of household members using improved sanitation, and so on. So I think she brings up a great point that there have been some really good WASH indicators that have also been used in these studies. So thank you, Maureen. We appreciate that. Then, Maureen, there's a question to you. I was curious about stress, such as ACEs, and early childhood development within developing countries. Have you been able to pull out those environmental factors of trauma within the studies you mentioned?
You know, this is a wonderful question, and the issue of stress, we are learning much more about that. I can tell you, for example, we did a meta-analysis looking at maternal depressive symptoms and children's growth that we published in the bulletin of the World Health Organization about 2 years ago. The first author is Pam Surkin, S-U-R-K-A-N, and we find that when children are raised in an environment where moms are have depressive symptoms, not necessarily clinically diagnosed with depression, you find a relationship with they're more likely to be stunted and underweight. When we look at the stress or early trauma, we certainly see that women in low and middle income countries are exposed to these issues, and it certainly is a concern. Most of what we know about it from a brain science perspective has come from more developed countries, so that we learn, for example, when women are under stress during a prenatal times, that it can have an impact on children's HPA axis, so it can deregulate children's stress reactivity, thereby leading to difficulties in terms of children's memory function. As we learn more about the neuroscience of it, then it becomes certainly concerning. So that's the risk. There's also a good news portion of it. The good news portion of it is that there are strategies that can help women and children overcome the stress, and some of that has to do with nurturance and attachment that can be protective both to women and to children. But I thank you for bringing up what's a very concerning issue, particularly in parts of our world where there are lots of stresses for women, either in war-torn areas, in extreme poverty, or certainly the food insecurity. This is an area that has not been investigated as much as it could be.
Maureen, thank you for that. I think the next two questions target environmental enteropathy and really target Jenny's presentation. The first is environmental enteropathy reversible? If a child is placed in an environment that removes the EE mediators, can they fully recover and reverse the stunting effect? And to go along with that, were the EE study results shared with the government and local government offices in those countries? And what was their input in providing community play places versus commercial play places? So Jenny, I'll turn that over.
Okay. Thank you, Helen. Yes, I would say yes, EE is reversible because there have been studies which have shown that military personnel and other people who had been working in some developing countries and had contracted EE through unsanitary conditions, when they returned to their home countries and received treatment for about a year, within a year they seemed to have recovered from EE. And so there is limited but some data to show that with consistent treatment, EE can be reversed, although the damage that may have been caused in the early part of life would have affected a child's cognitive behavior and other aspects of their life. And for the second question, the study we are undertaking is ongoing, but we are working very closely with government and people in authority. When I shared the early slides on our learning agenda, one of the things that I wanted to say is I had there, which I did not say, was the Nutrition of the Center establishes the Learning and Practice Alliances, which brings together research organizations and people in policy making and implementation in the governments, in the various governments, and it promotes learning and integrating the findings from our learning into into programming and also into government policies and implementation. And so government representatives are going to be closely linked to the findings, and we will share with them the outcome of the study.
Excellent, thank you. We're getting very close to our time of 11 o'clock, but there are two questions that remain in the question box, and I think we can address both of those before we sign out. The first one, and perhaps Maureen, you could comment on this one. It says integration among the organizational level is quite a challenge because of the funds. What is a good way to solve the funding problem?
Oh, wow. That's an interesting issue, is to have an enlightened funder. I think to the extent that a donor can be involved in understanding that if you're interested in if it's a development-oriented funder, then for them to understand that you have to improve nutrition in order to take advantage of the development. And that is why I showed the study from Bangladesh. Children react differently if they're undernourished, and in that case anemic. If it's a nutrition funder, then to help them understand that if you're trying to improve children's development, that nutrition is necessary, but it's not sufficient. That you really need the developmental component, the stimulation, the learning opportunities, and that's why I showed the long-term studies. So some of it is helping a funder look at a bigger picture, and that children need both of them in order to prosper. Yes, it's a challenge, and we are much more likely to be siloed thinking, and we're all looking for positive models of how these two fields can collaborate and work together. So I would welcome others who may have thoughts on how to do this, but I do think an interaction with the funder or the donor is a useful strategy.
Okay, so now that I told you we were down to our last question, we're not really down to the last question. A few more came in. So a question actually for either of you, if you have an opinion about this. From an implementation perspective, I think there should be tracking of costs as part of the M&E efforts to indicate what are the savings in implementing programming to entice donors and borrowers to move in that direction. So I guess that one is more of a comment.
I absolutely agree that I think sometimes, and this refers to the last question also, sometimes the ministry that you're working with is the Ministry of Finance. And to understand that an investment very early in life can have a long payoff. The difficulty is sometimes those that you're working with want the payoff today or tomorrow rather than the 30 years hence. But the two papers that I mentioned that were in Science were both heavily influenced, very heavily influenced by the economics and preventing health problems in the U.S. one and promoting earnings in the Jamaican one. So I could not agree more that these integrated ones should include economics.
Thanks, Maureen. And now a couple of questions for Jenny, two actually. Jenny, can you share some highlights on how interventions addressing WASH and nutrition in arid and semi-arid areas are handled where water is a challenge? And then to go with that, there's a follow-on question that says, well, how do you deal with communities that are not receptive to WASH practices? So Jenny, I'll leave those with you.
Okay, I'll start with the second one. How do we deal with communities that are not receptive? Usually we work very closely with communities, and different themes, communities accept different themes and different topics differently. And so working closely with communities and identifying who the influencers are. Earlier on when we talked about indicators, one of the things that I wanted to mention was the receptiveness and awareness of key people in the families and in the communities, such as, I mean, if you took the household level. In many places, it would be the husband or the mother-in-law, and also in the wider community, there would be the local chief or certain or different actors in the community who are influential. Working closely with these people is one of the strategies that we have found to be successful with being able to connect effectively with communities, and also building on communities' prior knowledge and structures within the communities to ensure that interventions are sustainable. And so working with communities who are not receptive may take longer, but it needs a strategy on identifying who would be your links and who would be the entry points, and also trying to identify community interest. And so a lot of engagement with the community is important, listening to communities to find out why they may be, they may oppose certain ideas, and understanding their point of view, understanding where they're coming from to be able to make entry into the context is very important. And so it's a combination of working with identified people and building on what exists in the community and close engagement with the community to build trust and to create enough awareness. As I mentioned earlier, telling communities not to keep animals in the house may not go down very well, but people understanding, trying to find out what is important to the community. For instance, in most poor communities, what is important, one thing that is important to them is children growing up and getting very good jobs and leaving the community, leaving the poverty and bringing some gains back to the community. And so if communities were made to understand how malnutrition or stunting affects the cognitive development of a child and threatens the ambitions they may have for the children of growing up to come out of poverty. And these are some of the entry points for the conversation and the dialogue that you would have with the community. And then coming to the second question, in arid, how we work in arid context. What we do, in Ethiopia, for instance, where we have some of our programs, there are certain areas where they are very dry and arid and very difficult to find water. What we have done is we have partnered with other organizations. We've had some partnerships to address the water issue. So in certain areas we have had to sink boreholes and things like that. So even if it is not the main focus of our program, we try to identify partners that we would work with to provide this. I hope that answers the question. Yes, thank you.
That was very good. There's another question here. This one I think is targeted more at Maureen, but Jenny, go ahead and answer if you want to as well. Are you aware of a recent project using care groups to integrate household-level promotion of nutrition and ECD practices in the home? Would this touch on the integration?
Okay. In care, we have used care groups in a number of countries to implement nutrition programs, nutrition and ECD programs in East Africa and in Asia recently.
Maureen?
Yeah, I'm not aware of the care groups per se. I certainly can say that there are programs in the field which are attempting to integrate nutrition and early child development at the household level. I can say that we have one in India called Grow Smart that has an infant phase and a preschool phase. So the infant phase is all in the home, and we're in the process of analyzing the findings from that, which were positive. And we have one that we're embarking on in Guatemala. I know that there are others as well. The Pakistan study had both nutrition and early child development at a household level. So this is really where the field is, and I know that there will be more studies, more evidence underway.
So perhaps I'll just close with some comments from Phil Moses. He wanted to let you know about a community of practice around behavior change, and states, in terms of working with communities and behavior change in WASH, I suggest participants consult 2 publications by the core group. One is called Designing for Behavior Change, and the second is called Manual on Care Groups. So I think we've hit on most of the questions at this point, and I'd like to thank our attendees very much for their attendance, and please continue to correspond with the speakers if you have additional questions. And I think that concludes our webinar, unless there are closing remarks from Jenny or Maureen before we complete this.
I would just say thank you very much for the interest. It's very, very exciting to see this number of people interested, and we look forward to much more work and much more evidence in the area. Thanks.
Yeah, I also want to say thank you very much to our participants and to the organizers, and I look forward to more partnerships for us to move forward with the work that we're doing. Thank you.